As already introduction we given, my name is Dr. Saqib. I'm working as Associate Professor at Aleem Gulab Devi Chest Hospital, Lahore. And today we are going to discuss about the challenges in the management of asthma. Let's start with the name of Allah. Auzubillahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Inna a'tainakal kawthar. Fasalli li rabbika wanhar. Inna sha'niyaka huwal abtar. Now, the COVID pandemic has changed the management of patients and as well as the delivery of the presentation. So today, the previous time we have to go to the to give lectures. Now I'm sitting in my office and delivering lecture to the audience. And let's start with the our presentation. The asthma is in sometimes is very easy to manage in the OPDs and sometimes it become very difficult in managing OPD, especially if we are managing a difficult to treat asthma, then the things become very difficult. These patients usually are taking and usually they are still complaining of dyspnea, chest pain, cough, and all those symptoms of the uncontrolled asthma where often the patient come to us in the difficult to manage asthma is should we change the inhalers, is there any benefit of other inhalers, what we are missing in our managing asthma. So the present presentation is about the discussion of these factors. So let's start with our presentation. So these are the contents we are going to learn in this presentation about achieving asthma control, MART approach, what is proactive regular dosing approach, and PRD versus MART, and real world management of asthma. Now, asthma control is it has two sides. One, you have to go achieve good control, and second, you have to minimize the future risk of poor outcomes. So, in order to what is the achieve, you have to achieve the good goals is that you have to decrease the daytime symptoms. Actually, there should be a no daytime symptom. You should have no nocturnal symptoms. You should have no limitation in activities, and you have minimal or no use of relief medication. And what this comes to the real world is that the asthma-related mortality this decreases. There are the decreased exacerbation, and the airflow limitation improves, and medical side effects ultimately decreases if you're using a minimum inhalers. So this improves the quality of life, airway inflammation, and bronchial hypertrophy. But the question is that can we achieve this in the real world? The answer is probably is difficult and probably is no. So these are the GINA 2020 guidelines, and it says that the assessing control should be carried out at the every step of the asthma treatment. So how we are going to achieve this is through the circle. That first of all we review, then assess, and then the adjust treatment. And this process goes on and on and on. It never stops in any stage of the asthma management. So in review response, we assess about the symptoms, their exacerbations, the side effects, the lung functions, and the patient satisfaction. And when we assess, after reviewing the response, is there, have we made a diagnosis correct? Is there any comorbidity that are contributing to asthma uncontrolled? Is patient inhaler technique is good? Or preference-wise, he is preferring DPIs versus MDIs? Or what are the patient's goals? Is he want maximum achievement or just want to just have a just good night's sleep? That's it. And after assessing this factor and discussing with the patient, then we go to the adjustment, which could be in the form of medication, non-pharmacological strategies as well, education and skills training. So the GINA guideline has two main difficult steps. One is step one, step two. Step three is a bit higher. We usually see in the step three in our clinics. But in step one, they have recently made changes about as needed low dose ICS formoterol or low dose ICS taken whenever SABA is taken. And in step two, they have now included, this is the daily low dose inhaled corticosteroid or as needed ICS formoterol. So how we are going to assess? The asthma control is assessed with the asthma control test. It has basically five components. What is the activity limitation? Second is the shortness of breath. Third is invoking due to asthma and use of delivery medication. And finally, the global judgment of asthma control. Each is numbered according to the points and it should be assessed in the last 4 weeks. If you have more than 20 points, then this is well controlled. 16 to 19 is not well and controlled, and 5 to 15 has a poor control asthma. So this is a study in 2024 patient, which has says the relationship between the asthma control test X score and the number of the exacerbation. The poorer the score, the more are the number of the exacerbations. For example, patient has five, which has more than 16 exacerbations in the last 12 months, as compared to the you can say one or more, one or less, about who have a 25 score. So managing and controlling asthma not only improves the quality of life, but in the future it reduces the number of the exacerbation. So we should achieve the maximum controlling of the asthma. So do we need a personalized approach for asthma exacerbation, or just we treat each and every patient, whether he's old, he's young, whether he's mobile, he's pregnant or not, to each and every patient? The answer is probably different. In a study in 50,000 patients, two-thirds did not exacerbate over a 7 period year, with half only exacerbating once. So this is only the this is the importance of the controlling of the management of the asthma control. Second, peak exacerbation is associated with increased risk inflammation, for example, eosinophilic and neutrophil influx. The exacerbation is not simple the worsening of the asthma. Lot of things changes at the baseline of the lungs. There is increased influx of the eosinophils and neutrophils that overall changes ultimately into the links to the remodeling of the asthma. Second, as we have a number of risk factors for exacerbation has been identified in these types of person. These include the number of previous attacks, the level of the asthma severity, and the level of the asthma control. The studies have shown that the ICS containing therapy may be beneficial for eosinophil exacerbation. ICS titrated to sputum eosinophil count significantly reduces eosinophilic asthma. And apart from the asthma, this has also been shown effective in the cases of COPD, where if you have eosinophilia, the giving ICS reduces the number of exacerbation as well. Now the topic is that achieving asthma control and reduction of the exacerbation. Why are we are failing at the management of moderate asthma? In terms of asthma treatment control, do you believe that the achieving asthma guideline directed control and reducing exacerbation risks are equally important? Answer is probably is no. Now there are two approaches now for the asthma control. One is SMART and what is PRD. MART stands for the maintenance and reliever therapy, and it's usually that you combine the one drug and it is used for both purposes, that you are using for maintenance and as well as for the relieving. And for this we are using formoterol usually. Now there's reduction of the future excess. This is a study carried out in various times that uses various forms of drugs, budesonide, SABA, budesonide formoterol plus SABA, where it is budesonide and formoterol is used as a buterol separate, salmeterol fluticasone combination with SABA, and then budesonide formoterol all together as MART. The most effective are the in these studies are the these are SFEs, that is solmitol fluticasone combination therapy with SABA, and when we use budesonide with formoterol and SABA. The rest, budesonide formoterol using as a MART has poor results in maintaining the long-term achievement and reducing the future risks of the exacerbations. This you can clearly point out. Now there are there are other 7 clinical studies that has clearly showed you that when a formoterol is used as a MART alone, it has resulted in increased needed liver activity at least once per day. The patient experienced nocturnal symptoms every night, 7 to 9 per night. They were asymptomatic less than 50 per daytime. Rest of the time they are symptomatic. And the rate of severe exacerbation was 1 in 5 per patient. So technically marked, although sounds good, but is not so much effective. Now that's come the other form of the treatment, PRD. There's a proactive regular dosing, that we give dosing on the regular interval rather than maintaining and asking the patient to just take the medication as much as necessary. PRD with SFC, that is salmeterol fluticasone, is associated with lower exacerbation rate when it was compared with ICS alone. This is also a study that is published in New England Journal of Medicine in 2016, and this has shown that SFC is much more superior than ICS alone, and especially in the age of 18 to 16 years when it is more productive, and a person is more active at that age. If ICS is used alone, there is an again study that has shown that there is timeline or settling of the various symptoms. No time night symptom settles very early. FE improvement takes about 2 months. PFE improvement at the morning against takes about 4 months. The patient no SABA use take about the 6 months, and histamine and other biochemical markers that are usually involved in the asthma sets very late, about 18 months or more. So the process still going on if you use ICS LABA, and this can be minimized if you use SFC as early as possible. This is a study, this is goal study, where guideline define asthma control, and that the gaining optimal asthma control. This was study done by published in the American Journal of Respiratory and Critical Care, and this has shown that with SFC treatment, an estimated 4 out of 5 patients who achieve control remain controlled even after 1 year. So this combination is very good for long-term treatment as well. And in the term of the patient benefit, these has minimal exacerbations over a period of time. It was so good initially this was studied in phase 1, and these patients were later enrolled into results was similar. Question arises: which study will mode of treatment will you prefer? MART, that is containing formoterol, or PRD, that is containing salmeterol with fluticasone? This is another study that is done using fluticasone, propionate, salmeterol plus fluticasone alone in achieving and maintaining asthma control as derived from GINA. And in their one of their stratum, this has clearly shows that the SFC that is superior than the formoterol alone in achieving and maintaining control of the asthma. Now, the other question is that the problem in the real world is that the patient adherence. I conducted a study in 2016, and this showed that in our population, it included about 100 to 120 to 150 patients, and it showed that about the 49% of the patients who were taking that inhalers were not adherent to their medication. Either they are skipping dose, or they are not taking even on the for months. So adherence in the real world is a real problem, and this has been clearly shown not only here but also in the other parts of the world. So when come to the adherence MART versus PRD, the adherence to the MART is 40.3% has uncontrolled asthma, 17.4% has a total control of asthma, and 38.3 has a partial control of asthma. And when PRD therapy is applied, 43.9%, in that almost 44% has a control of asthma, which is far better than if you're using MART as a single alone therapy. And partially controlled is almost similar. And so PRD has obviously benefit over MART when it was compared and it's used over a 1 period of treatment of the time. Yes, and when the effective long-term treatment strategies on exacerbation, it was shown that when both are compared, ICS LABA as a fixed dose treatment significantly reduces the risk of the severe exacerbations compared with the low-dose ICS alone, and with the combination strategy has similar rate ratios and similar rankings probability analysis. So ICS with LABA is far more superior than the alone ICS. Maintenance and liver therapy is better preventive exacerbation of an addition of SABA or LABA in patient on proactive regular doses. So this has been shown as well that maintenance and liver can be used in combination with your SFC inhaler, that is regular PRD interval doses. And in that it has clearly shown that it reduces the further exacerbation. If we recall, initially I've shown you the GINA guidelines that they have now included for step 1. If you are using ICS and formoterol, ICS should be given, and it has the similar benefits are shown here, that this reduces a significant amount of exacerbation and improvement of the symptoms. But it has one drawback. The patient uses more drug than that is required for the management of the asthma. In the real world management of asthma, does the perceived convenience of MAR translate really into the real world benefits? And do you feel that the patient can perceive their asthma symptoms correctly? Unfortunately, with asthma, there is poor perception of asthma in few patients, and there is an enhanced perception of asthma in the other symptom. In the patient who has poor perception of asthma, they unfortunately have blunted symptom of awareness. This results to be believed that the disease is well controlled, and this in turn results to delayed seeking and until their asthma attack becomes severe. And in the long term, this results into the remodeling of the asthma, and they unfortunately less likely to take an initiate plan. Opposite to that, there is a patient, few groups of the patient who has an enhanced perception of asthma. What result is that they result hyper responsive to airway, and they do frequent emergency services use, and they frequently use over medication. So in both ways, we have to make a balance. A problem with the MART therapy lies that it relies on the patient accurate perception of their asthma symptoms, and this has shown in the various studies that on many occasions these patients did not believe that their condition was severe enough to seek medical treatment. They just take their MART and then they just go along until their asthma become very severe, and then they realize that the window period which can be managed easily at home has been missed, and about 86% of the severe accessibility, 86 of the person don't know initially at that time. And the problem does not lie here, it lies everywhere. In UK, even the patient are confused. And the dispensing and what they have judged through that, the inhaler should be dispensed regularly. And when they compare to their pharmacy, when they found that the MART patient have they have poor adherence and inadequate patient education, and sometimes they use separate SABA for the liver therapy in addition to the MART as well. So MART alone is probably is not as good as compared to the PRT therapy. And variable therapy may offer convenience, but in majority of the patients, it results without good symptom control, and this has been shown as here as well. 44.3% as uncontrolled asthma, and only 17% of the patients achieve good control after 1 year of variable therapy, which is quite contradict to the PRD therapy. When used regularly, we achieve a very good control over 1 year time. This form of isoformitol therapy has been included in other guideline. The answer is like this: the BTS, the Japanese, and the other guidelines usually do not recommend as regular use of isoformitol as compared to the GINA. The same lies with the other other agencies. They also do not support too much this sort of therapy as a use as a MART therapy. Now coming to the Sabas that we are usually using Sabas too much. So I just want to give you some idea of the Sabas. Sabas are very good for only two conditions. One is the relieving of the acute symptoms, and other is the relieving of exercise-induced bronchoconstriction. And this is due to the because of the acute effect of the Saba that it starts within 5 minutes, and then it relieves the symptom over 4 to 6 minutes. But what problem with the SABA is that the patient is using too much. He is not taking the steroid. He is not reducing the inflammation. That is the background of this all exacerbation. And the patient missed that time, and he just relies on the relieving of the symptoms. And there's no treatment of the pathology, the back end pathophysiology that is worsening all his symptoms. This results overall in the much more severe exacerbation, and the studies have shown that if the patient who use SABA regularly, there are high chances of mortality. The mortality increases in these sort of patient. So SABA alone up to 1 to 2 times a month or something like that is acceptable, but patient is using too much. The steroid should be included with that, and SABA alone should be avoided. For exercise-induced, SABA is recommended and it should be used as a primary control. It should be taken for 15 minutes before the exercise, and the effects usually last for 2 to 4 hours. And usually, most of the persons they complete their exercising, and thus this is remain effective. And this SABA use is recommended in other studies as well. Now, strange is the MART is initially advocated as used as a both type of therapy, that is maintenance as well as relieving therapy. But if we compare to the other parts of the world, the SABA is still used in addition to the MART, and although the percentages varies with the various regions of the world, but the SABA is still prescribed. So when you are prescribing MART, although I in my personal feeling, the MART should be not used regularly, as we have shown you and clearly show that the MART is not good, inferior. It destroys the compliance and other matters and exacerbation as well. There's no need to prescribe SABA with that. As I told you, the more the patient using SABA, the more is uncontrolled asthma. So the asthma control can be assessed indirectly with the SABA use as well. The patient is complaining that he has to use more frequently SABA, then you have to assess and reassess and your patient. And according to GINA guideline, you may need to step up your patient to the next level of the treatment, or you have to find out the other contributory factor that has led to the increased use of the SABA as well. So the few words about the devices, as I told you, and in this previous study, which has shown that the poor compliance, the same study has shown that about 40% of the uses patient are using their inhaler device incorrectly. In my study in 2016 as well. So here about the MDIs, these kinds, this is the just you know that better than me that they contain cap, there is a canister, there is a metered valve, and then there is a plastic holder. So here is a video about how you are using proper use of Evohaler devices, or you can say that the MDI devices. First of all, remove the cap from the inhaler. Shake the inhaler well for 5 seconds approximately, because this allows the adequate mixing of the dosage. And then hold firmly by placing your index finger on the top of the canister and thumb on the bottom piece of the mouth. Sit up straight or stand up. You cannot take inhaler while lying down. So this should be clearly to the patient that either you are sitting up or you should be standing while you are taking your inhaler. Exhale away from the inhaler, that empty your lung. Usually we ask the patient to completely empty your lung because the exhalation is not understandable here. So उसको हम कहते हैं कि सांस पूरा बाहर निकालें, and उसके बाद then we ask the patient to put inhaler in your mouth and then press inhaler and start breathing at the same time. Now this is a bit tricky and difficult for the patient, and this is where the inhaler alone usually fails, and this is the most common mistake that patient usually takes. If it done correctly, then the patient should hold breath for at least 10 seconds and then exhale slowly through the mouth. This is the most crucial step, that you have to take breaths and press the inhaler at the same time. Any miscoordination or anything like that will jeopardize the use of inhaler directly. These are the common mistake: failure to remove cap, not holding inhaler upright. This is frequently we seen. The inhaler is put usually upside down, and exhalation is not corresponding to the inhalation. This I told you earlier. And failure to accentuate or inhale, inhaling too fast, inhaling through the nose. Patient may not know the device is empty. This is the drawback of the MDIs. Now the new generations have counter on that, and this has been reduced, but still the older devices don't have any such counters. So you should ask if he should know the date and when the inhaler has started, and then know the amount puffs he has taken, and then remember the dates. And multiple actuation without shaking between the doses and expiry date. Now, in order to minimize the this thing, it should be used with this spacer. This has audio with as well, so we will listen and then I will give you the input at the end. So there is no need of coordination, and results needs in the more delivery of the drugs to the lungs and the better result. Now these are the short form. There initially when we were studying and we were doing practice, there were large inhaler devices that was called a large airspace inhalers, and where you don't need to too much take breaths too much fast and slow. But the one thing is very much important, that you should not take breath too fast. If you are taking too fast, the drug will not deliver adequately to the lungs. So take slow and deep breath and then hold it for at least 5 to 10 seconds, or as much as possible as you can. Now the next is the echo haler or the discussion. This is the video. Okay, sir. I got the message that there is a problem with the hearing of the video. So I demonstrate. First of all, you have to open this device horizontally, and then you have to open it fully. Once you fully open, click the device, and I may start from the initially as we have a problem with the communication. So uh, I I repeat it again. Open this cover using a thumb grip. Hold it horizontally. Load this dose by pressing backward and away, gently breath away, and place mouthpiece in your mouth, and then take deep breaths and hold this breath for 5 to 10 seconds, and then you close it after moving from the mouth. So, and the closing of the cover from back, not from the pin of the inhaler. This is important. Otherwise, next dose will load on early. So this is the demonstration of live. Again, she has opened. She has made a click. Hold the devices as horizontally. Now she is taking deep breath, and she hold her breath for 5 to 10 seconds and exhaled out, and then it's the closure of the demand. Uh, this is the closure of the device. Common side effects or common mistakes again are failure to slide cover as far as possible, failure to slide lever fully to open the mouth. This is again a common mistake I have seen frequently, especially in the old age. They forget and they don't open, and then they take deep and deep breaths and say and think that the inhaler has empty, and then they bought another, and then they bought another. And one of my patient came with a complaint that this discus is faulty, so I told her the fault lies with the lever, not with the device. Holding in a downward position after dose preparation, so should make it horizontally, not downwards. And shaking after dose preparation, shaking is not required for these DPIs. Blowing into the device before inhalation, again, if you blow into the device, the drug will be dispersed in the device, and again, you will be unable to inhale anything. Again, failure to put in mouth and seal lips around the mouthpiece. Inhalation is not forceful from the start. This is the problem, or you can say the drawback with the DPIs. Inhalation is required. FE1 or is required to have a good dose delivery in the lungs. And finally, if you inhalation through the nose and failure of the patient when the device is empty. So in the market, there are many other devices, Rotaheller devices as well as pin devices. There was a study conducting that compared the flow rates of the various devices of Rotaheller as well as the pin devices. So what they found out that a major portion of the drug remained in the device undercharged, and the portion of the drug discharged from the device was lost in the oropharyngeal airspace when Rotaheller and pin devices are used. 15 to 18% of the total dose delivered from the rotaheller at an inspiratory flow rate of 30 to 120 ml, and 60 to 120 ml, 60 to 120 liter per minute peak flow rate required to use a pin device. So, much amount of flow rate is required. If you don't have so much sufficient amount of flow rate, inspiratory flow rate, then these devices will not deliver the drugs adequately, and most of the drug either will lost in the container, or it will lost in your passage to the airways or in the upper pharyngeal airways. Only 21% patient could generate sufficient inspiratory flow rate through pin devices. So this is the drawback of the pin or rotainer devices. As patient is not improving, then you should check the flow rates, and then you may need to reconsider your device or the other method of the inhalers. Apart from if you have ruled out the other causes of uncontrolled asthma as well. Now the comparison of SFC versus beclomethasone formoterol, there's not much difference apart from the extra benefit of early initiation of the therapy. However, it has some drawback that formoterol has particle size of less than 1 micron, which are less as efficacious because they may be exhaled out, absorbed in the bloodstream, or also get phagocytosed when considered as a formoterol body. And when compared to the discus and the other pre-filled DPIs, internal resistance discus has low, other has a medium resistance, and potency of the steroid is more potent, and beclomethasone is comparatively less potent when compared to the fluticasone. So coming to the children, it has been shown that the SFC is much more superior to the Montelukast, improving the lung function. And I have seen frequently that the children are being trained just alone on the Montelukast for a very long time, and the patient has an uncontrolled asthma. The only thing that they are not being put on the inhaler because of stigmata that is associated with the inhalers. कि जी मेरे बच्चे को इस उम्र में अगर पंप लग गया तो सारी जिंदगी क्या होगा. This is the commonest wording मोर सो और लेस बाय द पेरेंट्स कि जी इसका आगे क्या बनेगा, आगे इसकी ज़िंदगी कैसे गुजरेगी. तो उनको समझाने की बात ये है कि इफ़ योर चाइल्ड हैज़ अनकंट्रोल्ड एस्थमा देन ही इज़ मोर लाइकली नॉट टू गेट आउट of asthma when he reaches at the age of puberty or at the age of adolescence age. So controlling and maintaining asthma at early age should be our top priority. So in order to get out of asthma by the time they reach at their adolescence age. And the SFC has shown that it's much more superior in the children when using Montelukast alone. 45.8% compared to 28.7%. This is another study resulted in high control of proportion of children with asthma achieving asthma control, as I told you that. So feeling from the inhaler should not be any such fear from the physician point of view. You should encourage as Montelukast, although we can add on therapy as that, yet alone it is not recommended as fully in the children. Children are uncontrolled asthma respond better to LABA step-up therapy versus LRT, the low glucotrine antagonist, or as ICS step-up therapy alone. So when your patient is using ICS and he still has uncontrolled, so as per GINA and other guidelines, he should be LABA should be added in combination with the ICS alone, and the study has shown that this results in the better control of asthma. And this is the few form of asthma, and this is the inhaler devices. One is MDI, and the other is the discussed again by the Seretide. So in the end, I would like to all my audience and the GSK, including especially the Seretide group, for inviting and giving allowing me the presentation to you. Now I would like to hand over mic to Roxana for any comment and any question from the audience.
Thank you very much, Dr. Saqib, for a wonderful session, and thank you for enlightening our audience about the difference between MART therapy and the regular dosing. So, Dr. Saqib, one of the questions that we are having right now is how do you define that one patient किसी एक मरीज को MDI देना है या किसी दूसरे मरीज को ड्राई पाउडर इनहेलर देना है?
This is called patient preference, personalized approach. This do not depends on me. It's the patient preference. Some patient prefer they are more comfortable of using DPIs versus other more comfortable of MDIs. The second question is use of the inspiratory flow meter. Patient is so much old and sick. Inspiratory flow is problem with the DPIs, not with the MDIs too much. So if in older age, I will preferably use the MDIs as compared to the younger patients. And the next comes to the patient preference. What I have seen in the practice is that some patient complaint of the cough after using DPIs or a very bad taste. In that, I also changes to the these patients to the MDIs as well compared to the DPIs. So they usually behave better when they are shifted to the MDIs, especially with the spacer rather than alone than DPIs alone as well. So patient preference. The second is the inspiratory flow rate. These are the two main, I think, factors deciding to treat to start treatment with which of the following medications.
Thank you, Dr. Saqib. एक क्वेश्चन और जो आ रहा है कि for the treatment therapy or of MDIs or DPIs, if there is a comorbid condition, for example, if a patient is hypertensive or diabetic or some renal disease, तो क्या उससे इसकी efficacy में कोई फर्क पड़ता है, या do you need some dosage adjustment in such
No,
patients?
no, no. I don't think so. Okay. There is any change of efficacy or dosage because we are using in micrograms, and these drugs act usually direct on the lungs rather than there is minimal systemic absorption. So I think don't think so. Okay, there's too much with the dosing. What I think so, okay, is just a question background. Okay, sometimes the patient of renal failure or maybe cardiac, they usually develop the pulmonary edema. This also produces the wheeze. So this sometimes confused with the asthma control, that probably the asthma controls has gone worse. So they start thinking either the problem with the asthma. But what I suggest that one should rule out the element of pulmonary edema, and the older terminology of cardiac asthma for that card LVF should be ruled out before any major change in the management of asthma plan.
And definitely, and Dr. Saqib very rightly mentioned that whatever the patient is presenting with, every HCP who is connected right now, there is always a room of the differential diagnosis before an accurate diagnosis is made. तो आप लोग बिल्कुल साइड पे इन चीजों का भी
Obviously.
ध्यान रखें जी. So use of MDI device in children, does that lead to any growth retardation or any other abnormalities?
हाई डोज के साथ तो लिखा हुआ है कि देर इज ग्रोथ स्टंटिंग, ग्रोथ रिडक्शन थोड़ी सी हो जाती है, बट विद लो एंड मीडियम डोज देर इज नो सच ऑफ ग्रोथ रिस्ट्रिक्शन इन द चिल्ड्रन यूजिंग inhalers.
Okay, okay, great. Similarly, in the pediatric group, Dr. Saqib, I'm sure people are connected from everywhere. आपके पास भी ऐसी practices देख रहे होंगे. There's very much overuse of nebulizers to the extent के parents ने घरों पर भी रखना शुरू कर
Obviously.
दिया है. So what is your take on that? Use of nebulizer among children.
Nebulizers should nebulizers first of all should be discouraged. It should not be used. It should only be used in those patients who can't take inhaler even during acute attack of asthma, whether it's mild, moderate, or severe. Because the problem lies with the nebulization is that first of all you have to carry your nebulizer. You become dependent on the nebulization. You can't move around. Second, the amount of dosage delivered with nebulization is too much. It's in milligrams. So what happens in the lungs in the longer run? The lungs become dependent on high doses. There is a down regulation of the receptors of the lungs at the cellular level. So this results in the more amount of dosage. You need more and more dosage over passage of time to come this phenomenon of down regulation of the receptors. So in all cases, the use of nebulizers should be discouraged, and more so the inhalers. Whether you have attack of asthma, it should be used with the spacer delivers equally good dose, and the guidelines recommend that you should initially use the inhaler with the spacer even if you have attack of the asthma. So I suggest that the nebulization should be discouraged, not be used frequently.
And Bilkul, thank you very much, Dr. Saki, for shedding so much light on nebulizers. And I would like to reinforce and reiterate what Dr. Saki has just mentioned, that काफी regular practice बन गई है, क्योंकि हम लोग भी as a company insights generate कर रहे होते हैं different जीपी से भी, आरएमओ लेवल पे भी. तो एक आई थिंक लेवल ऑफ सेटिस्फैक्शन बन गया, और शायद एक ईज ऑफ यूज भी बच्चों के साथ पेरेंट्स ने इसको बना लिया, दैट यू नो जहाँ पे भी हल्का सा वीज हुआ, कुछ हुआ, या खांसी का अटैक हुआ, या कोई नाइट टाइम अवेकनिंग हुई, तो फौरन से एक दवाई डाल दी. और आप दवाई का जो डोज डाल रहे होते हैं वो भी कैलकुलेटेड नहीं डाल रहे होते. सो इट्स वेरी
That's
एक्यूरेट,
again
उससे बहुत हाई
वो
डोज
हर एक
जा
की
रहा
अपनी
होता है.
मर्जी होती है तो कितनी.
बिल्कुल बिल्कुल, डालने वाले की
The
अपनी
problem
मर्जी भी
lies
होती है,
in that
डायल्यूशन भी होती है.
the problem lies कि वो ना inhaler का stigmata नहीं लेना चाहते, तो nebulizer
बिल्कुल
don't give that stigmata. हालांकि उसमें कोई स्टिग्मेटा नहीं, मैंने
राइट.
पहले भी कहा है कि inhalers should be preferred or encouraged early, not montelukast, because अगर uncontrolled asthma रहेगा तो by the time जब adolescent आएगा और जो आपका chance of getting out of asthma है वो बहुत कम होता जाएगा if you have initially uncontrolled asthma. So it should be used as early as possible.
बिल्कुल डॉक्टर साकिब, यहाँ पे आई वुड लाइक टू आस्क अ क्वेश्चन from you as a key pulmonologist that we have on board here. कि ये जो स्टिग्मा है, आई एम श्योर ये इट इज नॉट बाउंड टू एन एजुकेटेड बैकग्राउंड और नॉन एजुकेटेड बैकग्राउंड। तो इसके लिए हमारे जो भी डॉक्टर्स आज हमारे साथ कनेक्टेड हैं, उनके लिए आप क्या
हम्म।
ऐसा स्टेटमेंट देंगे कि पेरेंट्स को या इवन अडल्ट्स को बोला जाए कि भाई जिनसे वो सेटिस्फाई हो जाए, अग्री कर लें इस चीज के ऊपर, दैट इट विल एक्चुअली इंप्रूव द
इट्स
क्वालिटी ऑफ
क्वाइट
लाइफ।
वेरिएबल, ये हर एक के लेवल ऑफ एजुकेशन से ना डिफरेंट है।
जी।
यू कांट प्रिपेयर वन वर्ड। जो एजुकेटेड है उनको आपको समझाए ना कि जी अगर आपके लंग्स देखें, यू हैव लंग डैमेज एंड दिस विल फर्दर वर्सन इफ यू डोंट कंट्रोल योर इनहेलर इन एस्थमा, सो दे एग्री वेरी स्ट्रेट अवे कि ओके वी विल टेक इनहेलर। जिन चिल्ड्रन, मैंने आपको जैसे पहले कहा कि आप उनको समझाएं ना कि भाई इफ इट रिमेन अनकंट्रोल्ड तो आपका जो आगे फ्यूचर रिस्क है ऑफ नॉट गेटिंग आउट एस्थमा बढ़ जाएगा, तो वो पेरेंट्स भी मान जाते हैं। बीच में अब रह जाती है जो एक जिनका थोड़ा सा लेवल ऑफ एजुकेशन थोड़ा सा अबिट कम है, उनको समझाना
हम्म।
थोड़ा सा मुश्किल होता है। और यूजुअली वही होते हैं मोस्ट ऑफ द नॉन कंप्लायंट, वो थोड़ी देर के लिए ले लेते हैं देन जो फिर उनको समझाया जाता है। पर यह है कि इन दी लॉन्गर रन जब 2-3 दफा मैं विजिट कर चुके होते हैं तो मैं उनसे इनडायरेक्टली पूछता हूँ कि हाँ जी जब आप इनहेलर लेते थे तो आपका दमा कैसा आता था। वो कहते डॉक्टर साहब उस वक्त तो बड़ा अच्छा रहता था। मैं कहा फिर आपको क्या जरूरत है कि आप बार बार दफा मेरे पास आए, पैसे खर्च करें, टाइम लगाएं, तो चुप करके क्यों नहीं दवाई
हम्म।
लेते रहते। तो उसमें कोई मेरी बात ये भी सुन लेते हैं कि चलो ठीक है दवाई लेते रहने, स्कूल रहता है एंड दे कंटिन्यू लाइक दिस फॉर एवर। तो ये हर एक का
ओ,
वेरिएबल्स है, कोई सिंगल सेंटेंस नहीं। मैंने इसलिए आपको तीनों कैटेगरीज बता दी, फिर इनको तीनों
बिल्कुल
को ऐसे
बिल्कुल।
टैकल करना पड़ता है मुझे।
And inshallah, we will see you next time. Thank you very much for your participation. Thank you, Dr.
इंशाल्लाह,
Saqib.
थैंक यू मैम, थैंक यू जी,
Inshallah.
थैंक यू
Allah
टू ऑल द
Hafiz.
पार्टिसिपेंट्स।